Hi, welcome to Glenohumeral Gurus, a podcast for clinicians with an interest in shoulder pathology. I'm your host, Margie Olds, and it's a pleasure for me to bring you these podcasts. The aim for the podcast is to deliver some clinically relevant content for you. I plan to interview people from all over the globe and talk to clinicians and researchers and anybody with an interest in shoulder pathology so that we can learn how to help these people better. So settle in and enjoy the podcast. Hey, welcome back to Glenohumeral Gurus podcast, and this time it's my turn in the hot seat while Kevin Kuppens talks to me around fear of re-injury after a shoulder injury, and we talk and we dig into that in a bit more detail. So this time my turn is an interviewee, and my host Kevin will lead the podcast. So welcome back, Kevin, and now I'm a bit nervous sitting on this seat.
Thank you. I'm also a bit nervous because, I'm getting to get the opportunity to bring up some hopefully good questions.
Yes.
Looking forward to learn from you. So let's dig into it. And obviously, it's about fear.
Yeah.
And I think more specifically, we will be talking about fear of injury.
Yeah.
But I was wondering, can you explain for me and for your listeners, can you explain just the basic things on fear in general? So we have fear of re-injury, but is it the same as, for example, fear of spiders or fear of pain or fear of underperforming? Because that's also something that is written in some of the orthopedic medicine. What is this thing that's called
Yes,
fear, and
that
then
what it
more
is called
specifically,
is,
yeah.
and I think we are starting to learn such a lot about this fear and what it is and what we understand about it. And just to backtrack a bit, I guess my interest from this came from working in shoulder instability. I would have then athletes who it looked like they were apprehensive. Maybe they had a positive apprehension sign, like clinical sign, but also that they were nervous or apprehensive about getting back into sport, and so after their injury. And so I started delving around in the research and trying to understand that more, and in the process of my PhD looked then around the kinesiophobia, which originally was developed for chronic low back pain, this Tampa scale of kinesiophobia, which is both fear of movement and re-injury. And so then for my PhD, we captured some of the kinesiophobia using that scale. I think, like I say, the scale was developed for chronic low back pain, but at the time of my PhD was the only thing that had been validated in shoulder injuries before. And so we used that scale really to try to see if that was a risk factor for recurrent injury. And even though I think the Tampa scale of kinesiophobia isn't specific in the version that I use for instability, we still found that it was both a univariate and multivariate predictor of re-injury, of having another recurrence after a first-time shoulder dislocation. And so that really got me thinking more about this, because it was like, whoa, so my scale wasn't perhaps super sensitive to find out what it is, but we are capturing something here that's worthy of further exploration. So just for clinicians to understand, as a univariate predictor, you get to see that increased kinesiophobia means increased risk of recurrent injury. But then if you compile it all with all the other variables still as a standalone, it still came out, where some of the other more common factors like contact injury and gender, they disappeared and were pulled into a bigger pool, but still kinesiophobia came through. And so about the same time I was looking at the ACL RSI, and then we looked at looking at how we could adapt the ACL return to sport after injury scale for the shoulder. And we worked with Kate Webster to try and understand what constructs that was measuring. And again, re-injury fear was the only difference between people who had had surgery and people who were managed conservatively after a shoulder instability event. So I really have been digging into this in a lot more detail. And we're still learning around that. I have been drawing on the research around fear of pain and fear of flying and fear of heights. I think there are some similarities there.
Yeah.
In that space, they use lots of virtual reality to address that fear. And so I've been wondering then how we can use virtual reality to address that fear. I recently published a paper around great exposure to fear eliciting images. I can make people frightened and reproduce their fear by showing them what aren't necessarily scary pictures, but shoulders in a
Yeah.
provocative position. I
Oh,
think
that's brilliant.
it's just such a fascinating area,
Yeah.
Kevin, and I think it's different than fear avoidance. Like if we think back to those models around fear avoidance behavior and chronic low back pain, my sense is that what you see after a shoulder injury in an athlete re-engaging in sport is is different, is not necessarily that maladaptive behavior. There's lots of discussion around whether it is fear of re-injury or re-injury anxiety. So some people would talk about fear as something that you feel and then move away from, whereas anxiety is an emotion that you feel but choose to re-engage with. So maybe re-injury anxiety is a more accurate description. I think it's really new
And
and novel, this
and
space, and we're still learning around that and how to measure it. And I think I've been doing some of that with the shoulder re-injury scale, but re-injury anxiety, there is another scale that you could measure that. I think the more we measure and the more we try to change, then the more we understand.
yeah.
I don't know if that
So
answers your question.
yeah,
Yeah.
that's a great answer of my question. What I'm struggling with a bit is like I think at a certain point during a rehab process or a pathological process or an acute process, it is very normal to be
Yes,
fearful of to have some anxiety.
yes.
So so do you know if some of these scales or measurement instruments they are able to let's say pick up the fear of the moment of fear of the type of fear that
Yeah,
is indeed going to be a problem or that is
yeah.
already a problem?
So I guess
Like
there's
if
two things around that. We know, like you say, the fear of re-injury and that anxiety changes during that rehabilitation process. It's very high at the middle, sorry, very high at the early stages, immediately after injury. What does this mean for me? My loss of athletic identity. And then as you move through that rehabilitation process, the fear decreases. But then again, as you begin to get ready to return to sport, that re-injury anxiety or fear, what we call it, increases again. So there is a natural U-shaped progression
okay,
through that rehabilitation process, which in and of itself is fascinating. We
yeah,
also know, like I said, that people with higher levels after an instability event, a dislocation, are more likely to have re-injury. And we know from some work from Argentina using the shoulder instability return to sport index that the cut point on that scale can predict then who is going to return to sport and who is not. So
Okay.
that the shoulder instability return to sport after injury scale in the 12 item and also the 5 item questionnaire that they have published is a predictor of return to sport. We also know I've recently met with some surgical colleagues at the New Zealand shoulder meeting, and we know that around 20% of people don't return to sport after a stabilization, and the primary reason of that is around fear of re-injury or
Yeah.
fear of failure. And I don't know, you talk about the fear of performance and the fear of re-injury. I I'm not, I don't know that they are the same things.
Yeah.
We started a qualitative study with Gisela Sol. We published last year around the glass shoulder, and we called it the glass shoulder because one of
Yeah.
our participants felt so fragile that his friends call him the guy with the glass shoulder. And so I wanted to understand fear in more detail, like you talk about fear of performance, fear of pain, fear of missing out. I wanted to delve into the detail. And what we learned was just the enormous impact of these injuries. That was truly humbling for me. Loss of
Yeah.
social identity, suicidal ideation, just the massive impact that a shoulder instability, dislocation has on people. I was a little bit
Yeah.
like, oh, also it's a bit bigger than fear.
Yeah.
The fear is a small part of that.
Yeah, but it opens up a whole can of like
Yeah,
new
yeah,
problems
yeah,
that
that's the
that were
problem.
probably always there. Yeah.
Yeah. And
Yeah.
I think,
Okay.
what I have enjoyed as a clinician and what my patients enjoy and appreciate is that I have that discussion really openly. How are you
Yeah.
feeling? How has your shoulder dislocation affected you? And I don't think
Yeah.
that's just the same for a dislocation. I think it's the same for swimmers, it's the same for lots of different athletes.
Yeah.
How has your shoulder injury affected you? To
Yeah.
understand, and some people say, oh, it's fine, it's a bit of a pain. And some people say, oh, so I can't get out of bed anymore. I'm not going to training. And they talk about that massive loss of athletic identity and who are they if they're not a rugby player, if they're not a swimmer, who are they? And it really opens. We talked in your podcast earlier around the that biopsychosocial model, but it really opens the door for those conversations,
Yeah.
and athletes appreciate it. It I think
Yeah. But as a clinician, you have to dare and ask
yeah,
that
yeah, I
difficult
think so.
question because sometimes you don't know what will come out of it
Yeah, you don't know. And I
yeah.
think and it's okay to be uncomfortable in that space.
Yeah.
I
Yeah.
think as a clinician, I
Yeah.
think it's really important to respect your boundaries. And so I just knowing who needs further psychological help that
Yeah.
isn't, and for me I just offer empathy and a safe space to express their emotion. Do you know, that's because
Yeah.
that's my skill set. I can do that. I
Yeah.
can't offer specific psychological tools or
Yeah.
strategies. And if you express suicidal ideation, then you're an immediate referral for me. So
Yeah.
just for clinicians to respect their boundaries, but also to understand the power of showing empathy and creating space for people
Yeah.
is
And you think so? So you talked about some of the instruments,
yeah,
like the shoulder instability, RSI.
yes.
Do you think like that one question that you mentioned can replace some of those instruments, or do you use, or when you use the 5 item uh,
Yeah.
shoulder instability RSI, do you use that one like
So
as
I
an opener for
measure, yeah,
conversations,
yeah, yeah.
or yeah,
That's how I think about them quite separately. I measure shoulder instability. I use that scale to measure their scale because then I can see if it's changing. Are
yeah,
things moving? Are things changing? clinically, I use that as an opener to understand. And so if I
Yeah,
ask that question, then I might think, oh, hey, let's use this scale to find that out in a bit more detail. Do you know, like that
yeah,
might be an opener that I would
yeah,
use. And if anything comes from that, then I would measure in more detail. I don't measure that. I routinely screen for kinesiophobia. I
yeah,
routinely do that in my clinic. Everybody who comes in fills out these big outcome
yeah,
measures, but I don't routinely measure for the shoulder instability return to sport after injury
no,
scale because as it stands at the minute is only for people who have had instability. We need to learn how
yeah,
to apply that concept to other shoulder pathologies.
yeah,
And there is some work coming in that space, I think. But
yeah.
yeah, and it's only probably for
So
athletes as well.
yeah, so and for the injured athletes, probably you will use
Yeah.
that instrument at the beginning, and then you continuously follow it up. Like for clinicians, is it like every 2 weeks or every month,
Yeah, I
or
don't think you
what's the
need to
time frame?
measure it again and again and again. You don't
No,
need
but
to.
you don't want to find out about the U curve.
I don't. Well, we know that there's probably a U curve. Do you know? I mean,
Yeah,
maybe if you were doing a research study, it would be interesting to see that
yeah,
change. But often I'm measuring at baseline, and then
yeah,
in my current practice, I am then clearing for in a one-off assessment, clearing for return to sport. So I think
yeah.
it
Okay,
depends on um, how you are using the type of clinical environment you have. I don't think it's necessary to measure,
no,
remeasure, remeasure. I'm not sure that as a every 2 weeks, what will that tell you? Because the fluctuations, we still don't know so much around how much it varies during the
yeah,
process. And maybe that's a really nice research project for somebody,
yeah,
but clinically, it's quite a lot to ask your athlete.
yeah.
It's a lot.
Let's find a master student or a PhD
Yes,
student.
exactly. Wouldn't that be wonderful? Because I
Yeah, could
I
be.
think knowing the journey, I think is really important. And really this
Yeah,
came from an idea from my clinical experience working with athletes, but now we can measure it maybe a bit more and maybe that would show us that U curve. Yeah.
good. So I have one other question.
Yes.
If we talk about like fear of re-injury, maybe fear in general, do you
Hmm.
think it affects like motor behavior or
Yeah.
motor control in one way or another?
Yeah, we're still learning about this too. And I work with a wonderful colleague at the Auckland Shoulder Clinic, Pradnya Gadkari, who's very, very interested in this space. And we've just done using the blaze pods, those flashing
Yeah,
lights on the wall. So
yeah,
we've just done a reliability study and then an instability population, one arm versus the other, but also measuring their SIRSI to measure their fear, to see if fear delays your reaction time. We know from some ACL research work and a PhD that looked at fear in ACLs that it probably disrupts your motor coordination. Clinically, I talk to patients about having a brain that's that's clouded by fear that you can't find the right muscles or you can't find
yeah,
them quick enough. Is there hesitancy? That relates to then re-injury. Maybe that's the link. I'm now postulating as opposed to
yeah,
maybe that's an idea. That's something that we 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 think might happen in an ACL population, but again, the research is very sparse there. It makes sense that that would happen. And in the environment of collision sports, it makes sense that if you hesitate, your muscles don't contract, you're not ready for impact, that then you predispose yourself to injury. So is a little bit how should we say is a because the more fearful you are you're going to get re-injured, then you actually are more likely to get injured. So is you think you're
yeah.
protecting yourself but actually you're increasing your risk. So It's been really interesting
Probably
to.
because I think some of these aspects has been shown in, for example, in low back pain with more like rigid behavior.
Yes.
Well, people not dancing anymore.
Yeah.
Yeah,
Yeah. You
my
forget to
my
move
colleague,
and you don't have that
yeah,
variability.
my colleague in clinic, when he meets a patient with like a relatively acute low back pain, he
Mm.
always starts dancing with them, like doing little
Okay.
dance movements just to find some release in a fun
Yeah.
way.
Yeah. And
Yeah,
the
and
rhythm is probably really helpful in that space,
yeah,
isn't
yeah,
it? You
yeah,
know, in the same way that
and
you still remember how to move, you still remember how to reach. And I think
yeah,
that's where tapping into this space in a virtual reality setting
yeah,
is really. I've had a wonderful chat with Beata Diocco
really,
about like virtual reality and how we could use that and what that might mean for fear of re-injury and how
yeah,
you could move differently in this virtual setting as an avatar and then
yeah,
translate that. But the research, I mean, it's evolving here in this space, but
yeah,
I know that showing people a scary one photo image, it's not scary. It's a photo of somebody falling over off their
yeah,
mountain bike when they're snowboarding, when they are playing rugby. But that creates a visceral response, and there is research around a physiological response of fear. So the pupils changing size, the sweating, the heart palpitations, all that is possible from one single image. I've
yeah,
once showed an athlete a picture I pulled up Google Images, which one makes you frightened, and she ran into the corner of my room, feeling very nauseous to get away from my computer screen.
really,
She's like, "Get that off my screen, get that away." I'm like, which one? For me, I don't feel any fear. And it
yeah,
was a picture of a dislocated shoulder.
yeah,
And it created that nausea response that had her running into the corner of my clinic.
yeah. It's
Is
becoming really personal for her, probably.
Yeah, very,
Yeah,
very. And
yeah,
then talking with Karen and Marianne around, is it memory, or is it then the apprehension or the position? Is it position related, or do I recreate the memory of that? And that's where digging into some of these concepts and these neurocognitive mechanisms that we're going to talk about in this course when I come to you is around
yeah,
what are the neurocognitive mechanisms of fear, and when we know them, what do we understand about that, and how can we use these theoretical mechanisms to
yeah,
address fear? I've recently been talking around protection motivation therapy that looks at appraising the threat and appraising then the coping skill of the athlete, and how we could use that theory to help treat fear. So it's an exciting time, but it's very
yeah.
much
It's
on
exciting.
the frontier of physiotherapy, shall we say?
Yeah, and just like in a previous life, I did some research uh, on chronic shoulder pain.
Yes, yes,
One of the first studies we did, it was in a group of dancers, professional. No, sorry, it was musicians. It was
yes,
like the violin players, etc. And we were looking for aspects of exercise-induced analgesia. So doing a protocol, but the
yes,
protocol was differed with an emotional induced analgesia. So we also showed like really scary pictures to
yes,
these musicians, and we did like a, a pre-test of pressure pain thresholds and
yes.
a post-test of pressure pain thresholds,
Okay.
and you did see like to say it right, like a decrease in the pain threshold, so an increased pain sensitivity.
Mm,
Um, so maybe there is some similar mechanisms
yes,
going,
perhaps.
but just to be clear, in those instability patients, there is no pain involved. Pain is is not
very
an issue?
seldom.
Yeah,
Very, sometimes back in that abduction external rotation position, they have pain in that
yeah,
position, but not necessarily, not, but I think they're
no,
separate issues. I think
yeah,
that, and that's why I'm careful around how we translate what that means into this population, because often then the patients will come to me not because of pain, because typically in an instability population that settles relatively quickly, but it's the
yeah,
apprehension and the fear that lasts. And the avoidance of activity
yeah,
because of the risk. I don't want to be in that position, so I don't do that activity anymore.
yeah,
So, which
okay,
if our job is to then get athletes back to sport, how do we deal with that, and how do we
yeah.
help them understand those emotions so that we can get our athletes back to sport?
But that was actually my next question. How do we deal with it? How so when there
Yeah,
is this patient coming in
yeah,
has a severe amount of fear
yeah.
regarding re-injury or whatever.
Mm.
How as a clinician, how can I deal with it? Or you think in many cases we need psychological intervention, or how would be your approach from a
Yeah,
clinical
so
point of view?
currently in New Zealand, I mean, it's different in different healthcare systems, I think. Currently in
Hmm.
New Zealand, our healthcare system is so overwhelmed that if I'm to refer to a psychologist, unless it's an acute case, often there is a massive waiting list for that. So I think
Yeah.
that really depends on the environment that you work in. I think that asking that question around how their injury has affected them and opening the space for that discussion first is a useful first steps. And like I said, we're going to talk about this a lot more in this course that we're going to
Hmm.
have, but around using that protection motivation theory to understand the threat appraisal, how the athlete's perception of the threat, what would happen if how do you perceive another dislocation? What's the effect
Hmm.
of that on your identity? What is the chance then of that actually happening? And is your perception actually what the therapists perceive? And then to understand also that appraisal of their coping skill, how they would how would they cope with that? What's their self-efficacy? We know that self-efficacy and being able to cope in this environment are, I think, very closely intertwined. So how can you enhance self-efficacy, and how can you then show an athlete from a treatment perspective, oh, I'm scared of falling. Well, if you progressively load so that you first of all fall from your knees and you fall from a small height, and then you progressively show the athlete that they are not going to dislocate in that position. And so they call this then inhibitory learning, that you can then create some cognitive dissonance in the athlete's brain so that they think they're going to dislocate, and then you show them that they didn't, and then
Yeah,
you draw their awareness to that fact. Oh, actually, oh, now I'm okay. And some of that we see
yeah,
in that return to sport testing that I've done. They
yeah,
feel their self-efficacy improves, their confidence decreases because they didn't realize they could do it, and now you've shown them that they can, and nothing bad happened. Oh, I thought something bad was going to happen. Oh, it didn't. Oh, I must be okay.
yeah,
And sometimes that's just a single one-off session.
yeah.
But having this skill
Sure.
set, I think, to make sure you don't then cause further injury in that assessment, so that it's graded exposure, because
Yeah,
what you could do is make that fear worse by
yeah,
by
of course.
having then an event and validating the fear that they feel. So,
So probably in many cases when you do like a sensible progressive approach, it would also capture the
yes,
fear aspects in your
yes, I
patient.
think so.
Sometimes we are probably good psychologists
I think so.
just by doing a progressive
Graded
regimen
exposure.
of of rehab. Yeah, yeah,
Yeah, and I
probably.
think what I learned from Beata and when we shared where we are in this space with virtual reality, that it's not so much actually doing the graded exposure or doing the event. But when you video somebody when they are doing the virtual reality, you have to show them. You have to then counter their perception with the video evidence on. I often would video athletes on their phone in the virtual reality setting. They're
Yeah,
like, "Oh, I can't move my arm." And then I'd give them the virtual reality. Look, this was you. Oh, was that
yeah,
me? Oh, maybe I can move my arm.
yeah,
So
yeah,
creating that cognitive dissonance and using inhibitory learning in that space, I think it's
yeah.
incredibly powerful. So making
Wonderful.
sure that not only the graded exposure, but also drawing the patient's awareness to that is very important.
Yeah. Okay.
Yeah,
And
fun.
then maybe to wrap up, Margie, just a question that's maybe a bit beyond our profession, but um, do you have any ideas in how surgery impacts fear, or maybe vice versa, how a fearful person would have impact on shoulder outcomes?
Yeah, such an interesting space, isn't it? Because we know from that work I did with Kate Webster that the fear of re-injury, if we compare surgical management with
Hmm.
non-surgical management, that actually patients who have surgical management have lower fear. But that's
Yeah,
around what we've told the athletes as well. So whether that's the like how much that impacts on them. It's funny you should mention that because I have an athlete coming to see me this afternoon who has recently, from recurrent instability, just now recovering from Bankart repair. And there was labral pathology, but he was so anxious and fearful of moving. I'm interested to see how he is because the fear of the surgery was part of that problem, and some of
yeah,
that is, like trait anxiety, where people have been diagnosed with anxiety versus um, injury related anxiety, and so
yeah,
to draw that distinction as well. So I don't have any golden answers there. It's a very complex
yeah,
environment, and I think maybe of the N of one, you treat the athlete and or the person in front of you, but
yeah,
provide that space for them to share their emotion and not to be frightened of what that might mean. And you don't have to have the answers. And by no means should you pretend or do I pretend to have that. But actually the sharing of that, then I often thank them for disclosing that information. Thanks,
yeah,
that's really important that I understand that because we know that this predicts this, and then I bring it back to the research to try to validate their experience, I guess. So yeah, we're still learning in that space and there's still much to come here, I think. So it's an exciting space to be in.
it's an exciting space. Yeah, really. Um, just maybe to really wrap this up,
Yes.
can you for the clinicians listening, can you provide us with one or two key aspects that you would
Yeah. Yeah. So
make the
firstly,
people came home
yeah,
when
to
when
take
when
home.
when
Yeah.
yeah, yeah,
Firstly, I think you have to ask the question. Firstly, you have to open the space in your assessment.
hmm,
How is this affecting you? And to create the safe space for people to share that. And then as a treatment, if you do nothing else, then you create some cognitive dissonance and you show the athlete through your graded exposure in a safe manner that actually they're not going to hurt themselves when they do
yeah,
that. Actually doing this doesn't mean what you thought, that your appraisal of that threat is not actually the truth in this situation. So to create
yeah,
that dissonance, I think is helpful. That's been my experience.
perfect, brilliant.
Yeah.
Maybe we can talk just a little bit about your plans coming to Europe in
Yes, I'm
September.
so excited. I'm
We're
so
looking
excited.
forward.
Yeah, I haven't been to Europe for a few years, so it's always a big trek from New Zealand.
Yeah,
So I have
yeah, of
then
course.
a shoulder, 1 day shoulder course in Sheffield through USA that is around shoulder instability and return to sport, and that is 1 day. And then we go to Ireland to meet with Adele Fanning, and again 1 day of shoulder instability, return to performance, which will be fantastic. I've been
Yeah, of
working with
course.
her remotely a lot, so that will be wonderful. But again, only 1 day, and then we come to Cessic, and we talk at the shoulder conference, and then a 2 day course in
So
Amsterdam.
it's a combined conference with the European surgeons and the European
Yes,
and especially Flemish and Dutch
yes,
physios. They will
yes,
be all together in Rotterdam. Will be a
yes.
brilliant conference.
Yes, that will be wonderful, won't it?
Yeah,
I'm so looking forward to talking shoulders for two. I'm
yeah,
really excited about that. So yeah, I'm presenting a workshop there at the physio conference, and again talking to surgeons around re-injury fear and recurrence. And then a 2 day course with Karen Heckman in Amsterdam, which really gives
yeah,
us a bit more time to dig into this fear. And it will
yeah,
be the same course that I then come to Belgium to talk more with more time around day one on shoulder instability, both from the traumatic instability, but also micro instability that presents like recurrent rotator cuff related pain. So to the spectrum
yeah,
of instability there, and then to have time to dig into this fear component and really talk around my experience of fear of re-injury and what I'm doing with athletes and patients in that space in the context of returning people to sport. So yeah, no,
yeah.
wonderful, wonderful opportunity for
Yeah, looking forward to that.
yeah,
Okay.
that would be fun.
Yeah. So
Cool.
I'm really looking forward to seeing you first in Holland during the
Yes,
conference,
yes,
and then 1 week later at our own space in
yes,
Herentals, close to Antwerp in Belgium, for
yes,
the 2 day course.
yes.
Um, and for now, I really would like to thank you for this very nice conversation about fear of re-injury in unstable shoulders.
Yeah, thank you very much. It was a wonderful opportunity to share my excitement.
Thank you. Bye bye.
As Kevin has mentioned, I'm coming to Belgium on the 26th and 27th of September for a shoulder course that concentrates on shoulder instability and return to sport. So it would be great to see you all there. Kevin has kindly made a 15% discount code that is GH Guru. So if you type this discount code into the Next Academy website, then you'll get a 15% discount. So thanks very much, Kevin. I look forward to seeing you all soon. And if you wanted an online shoulder course, then I have a range of shoulder courses, through from an introductory shoulder course through to return to sport and a shoulder instability course. You can access these courses on margieolds.com or flawlessmotion.com. That's flawlessmotion.com. And every course comes with a complimentary question and answer session so we can drill into your understanding of the key concepts of the course. You can also join our Facebook group, Glenohumeral Gurus, and follow along for the conversations and discussions on this page. And otherwise, I look forward to you joining us for the next podcast. Thanks for your time. Until then, stay well, take care.